So now we move on to the future of myopia management. Now, the question, what next, is something that the first time the patient comes to know, the parent comes to know that my child has myopia, their first question is, okay, doctor, what next? And you're like, okay, I'm going to start you on glasses. What next? I'm going to start you on atropine. What next? I'm going to do these measurements every 3 months. They're like, what next? Basically, they want to know, when can we get LASIK done for my child? So, what does the future hold for our myopic patients? What we need to know as pediatric ophthalmologists is that once a myopia patient, always a myopia patient. And our pediatric patients with myopia grow up to be adults with myopia, and we are their most trusted advisor to answer this question of what's next. Thus, our myopia management cannot be restricted to knowledge of pediatric ophthalmology. So the first case is one of my patients, Om. Then he was a 15-year-old teenager. Okay, so at the age of 8, when he came to me, he had amblyopia, first time detected with one eye of -5 diopters. He went through intensive amblyopia therapy, and finally at the age of 10, he had 6/6 vision for his 10th birthday. It was a big celebration. Then over the years, he didn't do his patching very well, wasn't putting his drops very well, and was not also doing his binocular vision therapy too much for the years of COVID. And at one point, he came and said he can't see very well with his amblyopic eye. And parents thought that was because he had stopped patching, he had stopped doing his vision therapy. But at this point, when I checked him, his vision was only finger counting in the left eye. And the fundus showed a retinal detachment. We referred him, and he got a scleral buccal surgery. Now, what is the management strategy here? The thing is, regular follow-up of patients is very necessary, and we did have a lot of dropouts during the COVID years when they saw that, okay, the glasses number may be the same, and especially for unilateral myopes or people with amblyopia, the child is also not complaining and they can go away with it. The other thing is doing IDO at every follow-up. Again, dilating them, doing an IDO may not be, something that we look into, but that is something that we need to counsel for. And because the child had his counseling and he remembered my counseling on the detachment, he was the one who told his parents that I don't think this is normal. And they, of course, said, no, that's because you have not been patching. And the parents were very sure that he has dropped vision because he's stopped patching. But it was he at 15 years old, he said, no, I really need to go to Dr. KUHELI. Whatever is the case, during COVID, he was like, no, I know this is not normal. And so that's so important that we do a very good counseling for them. So the management trends have changed from primary vitrectomy and for especially these young children who don't have posterior vitreous detachment, to do a scleral buccal. This is what I learned from my retina subspecialists. Now, this is a second case. Now, this patient incidentally happens to be from Cochin itself. So he took a video consultation with me. He had an exotropia and he wanted to come for a squint surgery with me. He had right eye -6 diopters and a left eye with -1 diopter, and but he had 6/6 vision in both the eyes. Now, the binocular vision showed that he had a left eye dominance. During our counseling, the conversation shifted: do we do LASIK first or do we do the squint surgery first? And this is when I explained to him between anisometropia and anisokinia, and that all 6/6 vision is not the same. And finally, what happened is that there's a difference between the vision, and after he got his LASIK surgery done, his squint improved a lot, and then we tested for dominance, and now he finally has vision therapy. So this is the management strategy, that we want to test for dominance after the child has started wearing spectacles. After even any myope has started wearing spectacles, I would always check the 3 things which we've already spoken about. After they've started wearing glasses is when I check for accommodative lag, because we need to check the lag wearing their best corrected visual acuity. The same thing with the peripheral refraction. I will do it wearing their spectacle correction. And the third thing which we should not miss is checking for dominance in these patients and giving them some kind of binocular therapy if required. So this question comes up: LASIK or squint surgery should we do a LASIK surgery first or a squint surgery first in patients of myopia? And I really like this study where they compared 13 patients, and they found that 11 of them, there was no change in ocular alignment or binocular function. But in 2 of the patients with high anisometropia, which was the case in my patient who had a difference of -4 between the 2 eyes, they experienced an improvement in binocular function, and their manifest deviation shifted to becoming intermittent or latent squint. And while I might have lost out on a squint surgery case, this patient, even though he's from Cochin, he took a video consultation. He had consulted so many doctors all over India, but I was the only one who gave him a different perspective, and he finally did not need the squint surgery. And you get raving fans instead of just treating one disease. We need to treat the patient as a whole. It's not just myopia happening to the patient. It's not just squint happening to the patient. It's a whole visual, the whole visual function is happening all at the same time for the patient. Now, this is the third case, which is an 18-year-old. This must be happening so many times in our practice. 18-year-old, she was a long-time patient of mine, and now she was traveling abroad for her higher studies and wanted to get refractive surgery. Now, as I said, that we are the best people to explain to them about LASIK or LASIK or wavefront guided or SMILE procedures. And this is the workup which we need to do as pediatric ophthalmologists before we refer them to refractive surgeons, that is doing a dry eye testing as, the pupil size, especially in the dark, especially important if the child has been on myopia treatment. And most of these patients are on low-dose atropine, and that is why we need to do this pupil size, especially in the dark, which you will see is different. And many a time, I do counsel them that they might have glare because they have been on long-term atropine therapy, but she did not have after her LASIK, and of course the wavefront and the corneal tomography. Now, the case 4 is again of a long-standing patient of mine. She was 21 now, -15 and -18 diopters spectacles, and her number was not shifting. Now, here the importance is that many a time we feel that the progression of myopia has stopped once the axial length has stopped growing or once the number has stopped changing. This was a long-standing patient of mine, and of course her vision was always poor at about 618, 612. But since we were deciding to either shift her on getting an ICL, which is an intraocular columnar lens, or a lens extraction and lens replacement surgery, she was not a candidate for LASIK. So these were the 2 options that we thought of. And I did an anterior OCT as well as a posterior OCT. Now, why do we want to do an anterior OCT and a posterior OCT in many of our myopia patients these days? Anterior OCT to check for vault. I'll just take 30 seconds. And the posterior OCT for any kind of PVD, ERM, macular tractions. Many of us think that myopia, we are only going to check the peripheral retina, which we do with the IDO, but we forget that there is a lot of central retinal conditions and vitreous changes which happen with myopia. And myopia continues to progress even when their eyes have stopped growing. And one of the biggest things is CNVM. And we have seen CNVM patients at 21, 22 responding extremely well with anti-VEGF injections. Just a single injection improves their vision a lot. So OCT angiography is what we got done for her, and we saw some neovascularization, and she improved her vision just by 1 injection of anti-VEGF. And of course, I did a refractive lens exchange for her. This is the study which shows that a meta-analysis where they've shown that refractive lens exchange works very beautifully in these patients, and there is not the fear of retinal detachment that we always feared for a long time, especially because we have such lovely imaging that we can do, and we can do their lasers much before we've done the refractive lens exchange. So the take home message here is that there has been an advancement in everything in myopia, right from early detection of myopia to machines that diagnose risk factors and early environmental modifications. Then there has been advances in the drops, the glasses we've already spoken about, the peripheral hyperopic defocus glasses, the accommodative lag spectacles, and we also now have the spectral light therapy, which Dr. Prachi spoke in our last session, be it red light therapy or blue light therapy. There's a lot of advancements in that. There is also advancement in our LASIK and SMILE procedures, and also advancements in complications of myopia, which always happen in our high progressive myopes, complicated myopes, and we must look at the central retina, peripheral retina, as well as vitreous changes for our progressive myopes. Thank you for your valuable time. Thank you.
Thank you, ma'am. Something I would like to also add is glaucoma, because high myopes have a very different approach to glaucoma for them. Yes, and often OCT gives nothing. OCT gives nothing, and that's often the go-to investigation for glaucoma for anterior segment surgeon. And the only way you can really talk about it is HVF, a field. And we've burnt our fingers. Yeah, we burnt our fingers. We've done an RLE for a really high myope, and turned out that he had steroid-induced or pigmentary glaucoma, and we had to go for MIGS because he was a young kid, and that took toll. And this guy who's in IIT had to stay back for 6 to 9 months from his university just for this. So now pre-op, anybody I do any investigation, I also get fields done.